Okay, for everyone who is on the call, hello, my name is Jana Bitton. I'm the Executive Director of the Oregon Center for Nursing, and I'm here with Dr. Rick Allgeyer, who is our Research Director, and we are here to talk about the most recent report that we released last month called The Demand for Nursing Professionals in Oregon. This is an update of some reports that we have done over the years, and Rick is going to give a presentation about that in just a second. But before we do, I wanted to, just in case there's anybody on the call that is not familiar with the Oregon Center for Nursing, I just want to let you know, the Oregon Center for Nursing is a nonprofit organization dedicated to providing the best information about the nursing workforce in Oregon through research and collaboration with other nursing entities, for the purpose of being able to provide good information for policy and planning decisions. Our research agenda almost always involves taking a look at the supply of nurses in the state, taking a look at the nursing education programs and the pipeline for nurses in the state, and then also finally taking a look for the demand for nurses in the state. And so this latest report is just specifically addressing the demand for nursing professionals. A little bit of housekeeping, we really do value your feedback, and if you have any questions, we'd like you to enter them into the dashboard that comes with the GoToWebinar. There's a place on that dashboard for questions. Let's go ahead and enter your questions into that dashboard. You can enter it at any time, and at the end, we will read those questions and have an opportunity to address those. So for now, I'm going to turn it over to Dr. Allgeyer, who can tell you about the report.
Good afternoon. Thank you very much for taking your lunchtime to join us for our talk today, where we're going to talk about the demand for nursing professionals in Oregon. So this is a continuing body of work that we've worked on. As you can see, this is the fourth study we've done looking at demand. We did the first one in 2004, a follow-up in 2010. The second to last one was in 2015, and again in 2018. So what this survey is it's really directed towards employers. We're not looking at, so one thing I want to talk about a little bit before we go too deep into our demand results is look at the difference between demand and need. You hear those words used interchangeably. We try to distinguish them. When we're talking about need, we're usually talking about societal need. Need for professionals or healthcare professionals in communities so that healthcare can be delivered to the residents of those communities. But when we talk about demand, we're usually talking from the reference of an employer, where they're looking for employees. And so when we talk about our demand survey, we're really looking at it from an employer's perspective, and we're asking them questions about how hard it is to hire nurses, retention schedules, those kinds of things. And when we ask the employers about the demand for nursing professionals, we're looking at about 5 different metrics. The first one of them is vacancy rates, open jobs. The second one we look at pretty carefully is turnover rates, which means basically, and we're using the simplified definition, it's employees who leave during the year at some point for whatever reason. The use of contract labor is another metric we look at. We also ask the employers to quantify how hard, how difficult it is to fill certain positions within their organization. And then we also ask employers about what their anticipated future demand is going to be. And the way we ask that question is we look at the number of budgeted positions for a variety of specialties and subspecialties within the nursing profession, and ask them if they anticipate increasing those budgeted positions, decreasing them, or having no change at all. So who are we talking to? In this survey, we asked employers from hospitals and health systems, long-term care facilities, home health and hospice agencies, and public health entities. And what we're doing is, and the reason we picked these is, one is they're basically facility-based or they're agency-based, so it's much easier for us to send an email to an organization and have them address it rather than individual nurses. And with these four entities, we cover about 75 to 80% of the nurses that are actually working in the state of Oregon. Yeah, about 70% of the nurses are being covered by one of these four sectors. So I'll give you just a little bit of information about our sample size. So we sent this survey to 67 hospitals, 130 long-term care facilities, 66 home health and hospice agencies, and all 32 public health entities within the state. One of the things we have seen, and we've seen this before in other contexts, is we saw a fairly low response rate. For instance, the hospital's response rate was 34%, long-term care was 29%, almost 30%, home health hospice was 45%, and public health was 34%. In some instances of survey research, those response rates aren't too bad. But given the small size of our population, those response rates really need to be bigger. So what that does is it limits us on how much we can break our data out, say by rural versus urban facilities or different types of facilities within one of the sectors. We're just unable to do that just because our numbers are so small. And just to illustrate that, so of the 67 hospitals that we sent surveys to, we heard back from 23. Of the 130 long-term care facilities, we heard back from 39. So you can see those numbers are pretty low, and it just inhibits our ability to be able to break data down demographically or geographically. So, so we're only able to really look at statewide numbers. The other thing we discovered this time, and we kind of saw it last time, but we saw it pretty carefully this time, is that the sectors themselves are becoming less well defined as we're looking at the system level, because of mergers and organizations buying, like for instance, home hospitals and health systems also own long-term care facilities, and they also own or have home health hospice organizations within them. And so when you're looking at the facility level, it gets a little tougher for us to readily define this is a hospital, this is long-term care, because there's been so much mergers in that. So that's creating a little bit of an issue for us, but we had at least enough numbers that identified as a hospital or long-term care system that we were able to break it out. I'm going to talk a little bit about key findings. So when we talk about the numbers, you'll have some idea kind of where we're coming from. The first key finding is that employers are facing difficulties in recruiting, hiring, retaining qualified nurses across the spectrum of healthcare. We're seeing in all four sectors we looked at. There are data that suggest that the hospitals are somewhat better off. They have somewhat of an easier time hiring nurses. They also seem to have are better at being able to hold on to them and retain them. One other thing, the second one was that the rural communities across the state are facing increased pressure to recruit and retain nurses, and employers may be relying on contract labor to a greater degree, either traveling or agency nurses to fill vacant positions. And one thing that was kind of interesting to us that isn't on the slide, but when you go through the data, what we're going to find is some of the most difficult positions to fill are staff nurses. So when you think about it, you think about, oh yeah, we're going to have difficulty with intensive care, intermediate care nursing, labor delivery nursing, and that's true. But when we look outside of the hospital systems, the organizations reporting that the hardest thing they're having is hiring is staff nurses. So here is the first set of data. This is basically vacancy rates and turnover rates from 2004 to 2018 in hospitals and health systems. One thing I do want to point out is that in the report, when we provide the results, we actually had everything done by sector of healthcare sector. So within it, we had all the data for hospitals and health systems, and then we moved to long-term care. In this instance, what we did is we sorted it by metric. So we're going to talk about vacancy and turnover rates for all four sectors, and then move on. In the report, it's easy to flip back and forth so you can compare metrics across systems. When we're doing in this kind of a presentation, it's more difficult to be switching back. So what we want to do is have everything at least proximal to each other so we can make more direct comparisons. So here's the first data slide that we have on hospitals and health systems. And what you can see is that the vacancy rates for hospitals are reasonably low. They range from 4.5% in 2004 to 5.3. We've had a little bit of movement in the interim years, but generally it's been very stable. And then when you look at the turnover rates for hospitals, they're very stable. I mean, it's been 10.6 to 11.8. It's been really, really stable over time. Now, the question you may ask is, why are we looking at these two things? Well, vacancy rates serve as an indicator. So we're not really able to ask the employers directly. If you were looking at demand, you'd want to say, okay, how many LPNs do you need? How many bedside nurses do you need? How many nurse administrators do you need? That is really difficult information for employers to give us. They don't really, it's so dependent. I mean, the systems and the environment and the economy is changing reasonably quickly. It's really hard for them to nail it down. So what we do is we ask a lot of proxy questions, and we're trying to get a general sense of how much difficulty or how easy it is for employers to find nurses, to hire them, and keep them. And we're just, so it basically gives you an impression. You look at it 4 or 5 different ways to be able to give you an impression about how hard it is or how easy it is for systems. The turnover rates reflect the ability of the employer to retain nurses, and this is a good indicator of the stability of the workforce. If you see really high turnover, you know you're moving people in and out of that system pretty fast. So for the hospitals, it appears that it's reasonably easy for them to find and hire nurses, and it's reasonably stable in that they seem to be staying. When you compare this to other sectors like long-term care, you see a very different picture. For instance, our turnover rate in long-term care systems is 34.6%. That's really high. That basically means that a third, just a little over a third, of the workforce is changing over every year. They also have a very high vacancy rate of 28%, which means that nursing long-term care facilities are having a hard time hiring and recruiting and hiring nurses. You will also see that unlike in the hospitals and health systems, long-term care was much more variable. You'll also see that in 2010, they had a fairly low, for long-term care it was low, 10.3%, and a turnover rate of 21.2%. We're attributing that dip in both the vacancy rates and the turnover rates to the economic downturn that we had right around the turn of the decade. And you'll see that evident in other sectors as well. As moved on to home health and hospice, again, you see a small dip in the vacancy rate in 2010, but you don't see anything in the turnover rate. For home health hospice, the vacancy rate is 12.2% in 2018, and the turnover rate was pretty high at 30.2%. But for the past 8 years, from 2010 to 2018, the turnover rate has been reasonably stable. It's varying by a couple percentage points. And the vacancy rate has been jumping around, but it has come down a little bit in 2018. There is some similarities between home health, hospice, and public health that I'm explaining in just a second. Again, in public health, which is what we're looking at right now, you see a vacancy rate of just a little over 10% and a turnover rate that's approaching 30%. What you don't see in home health, hospice, and in public health is you didn't see any decline in 2010 due to people holding on to a job because of the Great Recession. So we were trying to figure out why that was so, because you would expect that those kinds of those broad economic conditions would impact all healthcare sectors about the same. Well, one of the things that we're thinking is that when you look at home health hospice, which had a very high turnover rate in 2010, and public health, which was not high, it was on a trajectory upwards, is the workers in those two sectors tend to be much older than workers in hospitals and health systems and long-term care. For instance, almost half of the nurses working in home health, hospice, and long-term care and public health, home health, hospice, and public health are over the age of 55. That's half of the workforce in those two sectors are older than age 55. In hospitals, only 27% of the workers are older than 55, and in long-term care, it's 37%. So what we're thinking is the reason we didn't see a drop in turnover is because retirement is part of turnover. And so when you have a workforce that is half the workforce over 55, you would expect to see retirement. They may delay retirement for a while, but at some point retirement has to happen. And so we're thinking that one of the things that muted the downturn in turnover rates in 2010 due to the recession was just an older workforce that continued to retire, albeit somewhat slower and slower rate, but they were still retiring nonetheless. Right now, what we're seeing is we expect these numbers to stay, especially like in home health, in hospitals, with the numbers being so stable. We are kind of attributing those to floor levels. They could come somewhat lower, but it's really, really stable, and we don't expect those to be changing over time. Now, with long-term care, you see it increasing, and it's pretty high. You also see vacancy rates going up. And so we'll be watching that really carefully over the next couple cycles, just to kind of get a sense of where this is going. The next thing we asked the employers for was information that helped us quantify how difficult it is to fill certain nursing positions. So what we did is in our survey is, and you had the full set of data in your reports. So like if, for instance, if you look at table 3 on page 5, which gives you all of the specialties and of nurses that we asked for. What we ended up doing is we asked each employer whether a certain position like unit manager or operating room nurses was not difficult to hire, somewhat difficult to hire, or very difficult to hire. And then what we did is we created an index for this. So we created an index for this so we could rank which sectors or which staff occupations they had a really tough time doing. So for instance, in hospitals, if for every hospital that said that hiring a unit manager was easy, we gave them 1 point. If they said it was somewhat difficult, we gave them 2 points. And if it was very difficult, we gave them 3 points. And this is described in the report, but I wanted to explain it just a little bit so you can understand what that index score means. That's on the 5th column over on the report. Then we just rank them. So basically what it does is it gives us a way of weighting the responses so that a response of very difficult got more weight than a response of very easy. And then we did the index because we ran into situations where we had a couple instances or a couple occupations where only two entities responded, but they both said it was very difficult. And so when you just look at the sheer percentage, it was 100%. But we only had 2 facilities out of 30 that responded back, and so we wanted to weight them also for how big the facility was. So that's why we did the index, and you can see those complete tables in the report. So for difficult to fill positions based on that index, I've listed the ranked occupation for each 4 sector here. And for hospitals and health systems, you see the most difficult position to fill across. And remember, this isn't for a specific entity. This is across the whole system or the whole sector. So for hospitals and health systems, they report that unit managers are the most difficult. Operating room, nurse supervisors, critical intensive care, and labor and delivery nurses are all very, very difficult to fill. For long-term care, staff nurses was number 1. New graduates was 2. LPNs was 3, resident care managers and infection control nurses round with the top 5. For home health hospitals, again, staff RNs, LPNs, nurse supervisors, new grads, and nurse administrators round out the top 5 most difficult positions to fill in home health hospice. And for public health, it was staff RNs, new grads, nurse practitioners, case management, and school nurses. So what's interesting here is the report is interesting because it shows you what is difficult to fill and also what's not. But what you glean from the data that we're presenting right here is that in three of the four sectors, staff RNs are the most difficult position for them to hire. Now that has a couple, there could be a couple of reasons for that. One is in long-term care facilities, home health hospice, and public health, staff RNs are probably the most numerous, where in hospitals you have a little bit more diversity, although you have many bedside nurses, but they have so many different departments and stuff that people are split off into labor and delivery and stuff. So it could account for the fact that hospitals don't have their frontline working nurse is split into a lot of different occupations, where in long-term care, home health, hospice, and public health, they're not. But it is interesting to see that they are having great difficulty hiring staff RNs and new graduates. One other question we asked all of our employers is, we're looking at the use of contract labor. We've been on some rural listening tours with the Oregon Office of Rural Health that go to small community hospitals, critical access hospitals throughout the state, throughout the rural parts of the state, and gives us an opportunity to talk to administrators at the hospitals to find out, but you can get more anecdotal information, but you can find out some reasoning behind what's going on. And they were suggesting a lot of the hospitals are using traveling nurses because they're having, especially in rural parts of the state, they're having difficulty finding nurses. And so one of the things we looked at was the comparison between 2015 and 2018 for the use of contract labor. In this data, we're only looking at traveling nurses and agency nurses as contract labor. And then, of course, the contract labor is just basically the combination of both of those types. So in hospitals and health systems, we actually saw an increase of about almost 10 percentage points from 2015. 91% of hospitals reporting back to us reported they used travel nurses in 2018. We're just more than half of hospitals used an agency nurse. Taken together, 91% of hospitals and health systems are using contract labor, compared to 82% in 2015. In long-term care, the numbers are much smaller, and they seem to rely, so like in hospitals and health systems, it looks like they're relying more on traveling nurses to fill positions. In long-term care, they rely a little bit more on agency nurses and traveling nurses. These numbers are really pretty small. The percentages are small, and also the numbers. So for instance, in 2018, the 2.7% who used traveling nurses is really one facility. And then there were 8 facilities, which is 21.6% that you see that used agency nurses. And so what you'll see is from 2015 to 2018, the use of contract labor in long-term care facilities, it went down just a little bit, but the numbers are so small it just means one less entity was actually utilizing contract labor. We'll see the same kinds of things in home health hospice and in public health. The percentage in using contract labor in home health hospice was 5.3% in 2015. It jumped to 8.0% in 2018. And while that looks like a moderately substantial increase, it really isn't. It's one. It's one more entity is using, or 2 more entities are using traveling nurses and agency nurses, compared to 2 that were using agency nurses in 2015. So we're using a little bit more traveling nurses, but again, the numbers who are actually utilizing is really small, only 8%, which is basically 3 entities are using contract labor for home health hospice, which suggests it's not really being used that much. And we're also seeing exactly the same thing in public health. 25% that use agency nurses. That reflects one public health entity. So you don't see much, but what is interesting is we are definitely seeing utilization of contract labor in hospitals and health systems. In fact, almost every, so of the 23 hospitals and health systems that responded to this question, only 2 of them did not use contract labor in 2018, whereas 21 did. So you can definitely see the difference in the use of contract labor across the sectors. The last set of data I'm going to go through a little bit more slowly because it's there's a lot on the screen talked about. So one of the things we asked each employer across sectors was, what did they expect? What did they expect to change in regards to their budgeted positions for certain positions of nurses? And so we asked them about RNs with the BSN versus RN with an ADN, or basically an RN with a bachelor's degree versus a registered nurse with an associate's degree. Nurse practitioners, we also looked with nurses with the doctor of nursing practice, the DNP. We looked at new graduates, RNs with a master's in science in nursing, certified nurse registered anesthetist, clinical nurse leaders, LPNs, clinical nurse specialists, and RNs with ADN. And what we basically are seeing is across the board, entities are reporting that they're going to be increasing the number of positions, budgeted positions within their facility for those positions. RNs with BSNs, 82% of hospitals reported that they were going to increase the number of positions for those types of nurses. 0 said they would decrease it, and 17% said they would have no change. Nurse practitioners, 81% of hospitals want to increase the use of the number of budgeted positions for nurse practitioners. Just under 5% say they will likely decrease that number, and 14% said no change. And so you can go through and look to see how different attributes of the nursing workforce are being budgeted differentially. So it looks like in hospitals and health systems. And I can compare this directly. So if you look at the very bottom of that table, you'll see RNs with an ADN or diploma degree, which is the associate degree or the old diploma degree that some nurses still carry because they were grandfathered in. But what you see that for RNs with an ADN, only 18% of facilities say they're going to increase it, but 63% say they're actually going to decrease the number of positions for that type of nurse. Whereas with RNs with the BSN, 82 are going to increase it. No one's decreasing that number, and 17% say they're not going to change. There are also things like LPNs, clinical nurse specialists, where most organizations say they're not going to change those numbers. And we run into this issue here. We're also going to run into the same type of issue in long-term care, home health, hospice, and in public health, is that because, just say for instance, in home hospitals and health systems, only 25% want to increase LPNs, 25% want to decrease LPNs, and 50% want to change. What we don't know is we do know that there are very few LPNs in Oregon. In 2016, we only had just a little over 4,000 LPNs practicing in the state, and just under 5,000 LPNs that were actually licensed in the state. And so what we don't know is it because the employers don't want that that they're changing the makeup of their workforce and actually aren't interested in hiring LPNs, or is it the fact that LPNs aren't available? There's so few of them that there's just not enough of them for every entity that wants them to hire them. And the same with clinical nurse specialists. There's a couple hundred in the state. And we don't know if the increase or the no change is because they don't want that position, or it's because there's just so few available. Hospitals are saying, I'm not even going to try to find that position. I'm just going to replace it with something else. We don't know that. This is a much more exploratory type of study, but we still have lots of questions. And, as most good research what happens in most good research is that it definitely generates a lot more questions, and those are the kinds of questions we're definitely going to be looking at. It gets more pronounced as we move into other sectors, so we can look at long-term care. We see different patterns. For instance, almost half of the facilities in long-term care facilities want to increase the number of physicians with an RN with an ADN. And while a lot of them, and a much smaller amount or much fewer facilities want to hire or increase the number of budgeted positions for RNs with a bachelor's degree. And so you can see that for the positions with the most increase are RNs with an ADN or diploma degree, RNs with a master's in management, new graduates, RNs with the BSN, RNs with a master's of science in nursing, certified nurse registrars anesthetists, RNs with the DNP, LPNs, clinical nurse specialists and stuff. What's interesting with this is very few of the facilities are actually decreasing the number of budgeted positions in those things. The biggest one is the RNs with masters in management, which is about an 8.3% decrease. The majority of them are either increasing those number of positions or they're not changing. In long-term care, very few are actually decreasing the number of budgeted positions. In home health hospice, we see, again, a different pattern. 83% of home health hospice agencies, they want to increase the number of nurse practitioners. 0 wanted to decrease it, and just a little over 16% wanted no change. The same with the RNs with the BSN, RNs with an ADN are both being increased by very comparable levels, 68% and 66.7% respectively. New graduates, 65% of organizations want to increase the number of positions for new grads. 50%, a little over 50% want to increase it for LPNs. What's a little interesting here is that in home health hospice, for home health hospice employers, about 11% want to decrease or expect to decrease the number of budgeted positions for RNs with an ADN. And about just under a quarter are going to hold it steady, about a fifth, a little over a fifth of them are. For clinical nurse specialists and CRNAs, they're not changing anything. They also hire, there's also very few of those positions in home health. The last we looked at is public health. Excuse me. And in public health, what it basically looks like to me is that everybody's kind of holding on to the status quo. They do want to increase the number of positions for RNs with the BSN. About a little bit more than half of the facilities wanted to increase the budgeted positions for RNs with the BSN. A little over a third said no change. Almost 10% said they were going to decrease that number. For RNs with an ADN, 22% was going to increase it. Almost 80% had no change. Nurse practitioners about the same, although nurse practitioners about 11%. And remember, since these numbers are really small, that's one entity was going to decrease. But for the most part in public health, they're not changing the number of budget positions for really anything. And that's partly due to the nature of public health versus other entities. Since most public health entities are public entities, their funding and budgeting is much more restricted in growth as compared to organizations within the private sector. So taken together, I mean, we get a general sense of looking at these 4 slides. Excuse me, of the nature in which organizations are interested in filling positions based on attributes of the nurse. So you'll look and see across many, especially like in hospitals and health systems, everybody wants to increase the number of RNs with the BSN. They're also seeing a lot of hospitals and health systems also want to increase the number of nurse practitioners. In long-term care, it's kind of the same thing. You're seeing RNs with an ADN or a master's in management, or new grads, or they want to hire those kinds of folks. But everybody's really talking about hiring, increasing the number of budgeted positions, and very few organizations talk about actually decreasing budgeted positions. In most cases, they don't plan to change over time, but it does give you a sense with the idea that's in the back of your head saying, okay, for some of these positions, I don't know if it's because they don't want them or because they can't find them, which are two really different questions. But if they can't find them, they'll replace them or they'll utilize other types of positions to fill those kinds of jobs. So taken together, it gives you a general sense that hospitals and health systems have a generally easy time to do it. They do have trouble finding specialists. But once they get folks on board, it's reasonably easy for them to hold on to staff. That's not true in the other four sectors. In long-term care, they have difficulty time hiring staff. What they really need is staff RNs. And once they get them, they don't stick around as long. They're having a hard time holding on to them. In home health, the situation is somewhat similar, except because of the agedness of the population or the workforce within home health hospice. You still see high rates of retirement, which is turnover, which maintains the turnover rate at a reasonably high level, and we see the same kind of thing in public health. I'm ready to take some questions. That really concludes the data presentation part of today's webinar, and we're open to taking questions.
Thanks, Rick. Kelly, who is our operations manager, has put links to the report and also the slide deck that Rick has here as a handout. So if you're interested in downloading those things or going to the OCN website to take a look at the report in its entirety, that's where you can access it. So while Kelly's pulling up the questions and getting ready for that, I just wanted to touch base. We did receive one question prior to the webinar even starting, and that was related to clinical nurse specialists.
Yeah.
And the question that we heard about from clinical nurse specialists is the concern that there hasn't been a CNS program in the state of Oregon for about 10 years now.
Right.
And so I think that the question was, given what they know about outcomes for people with CNSs, what are your thoughts about the lack of a program and the lack of CNSs in the state?
Well, I mean, as Jana said, we haven't had a program for over 10 years, and one of the things that we're seeing is the sheer numbers of CNSs within the state is really small. I think in 2016 we had 186.
Mm-hmm.
And so when you have numbers that are that, and almost all of them work in hospitals, at least according to the survey data that we have access to. And so what you end up with is, because they're just unavailable to the other in the other sectors, long-term care, home health, hospice, and public health. And it's been this small, and I've gone back through numbers of years of our data, and those numbers have been small consistently. And I think what ultimately happens is that, and it's kind of the same thing we're seeing with LPNs. We hear a lot of nurses saying, or a lot of facilities saying, we really would like to have an LPN, but we can't find any. Mm-hmm. So we either go to a certified nurse assistant and divvy up the job that they can do, and then give the rest to an RN, or they just said the heck with it and just hire an RN to kind of fulfill those things. And we think the same kind of thing is happening with clinical nurse specialists. We don't have a lot of them in Oregon. They do work in most of the ones that we do have work in hospitals. And I think other employers in different sectors have kind of given up. If you look back at go back real fast. Oh, that's okay. Yeah, so if you look at in public health, they're not changing anything. And again, in home health hospice, which is at the bottom, nothing. And in long-term care, they increased it a little bit, but still 80% of the facilities aren't going to change the number of budgeted positions for clinical nurse specialists. And even in the hospitals, 21% say they want to increase the number of budgeted physicians for a CNS, while almost 80% have no change at all. So my guess is that because of the lack of program, the only way that we're really getting new CNSs into the state are through endorsements into the state, which when we've looked at the endorsement data, and the endorsement data is important to look at because so many of the nurses in Oregon working right now do come in through endorsement. There's just so few CNSs coming in through endorsement. I think a lot of facilities outside of the hospital sector have kind of just given up.
Okay, and we have a few more questions here, but Kelly, it's on our side of the screen. It looks a little funky, so if you wouldn't mind, would you mind reading the questions for us, please? And if she does not come on, I might pop this out. Okay. All right, so we haven't heard from her, so let me just check and see if I can. Oh, here we go. Okay, so this is a better way for us to look at it. So apologize for that. So it looks like there were a few questions already about the CNSs. And then there was a question, how do you define rural hospitals and health systems?
We define it using the same method that the Office of Rural Health uses. So when we're defining rural communities or rural hospitals, we're using the exact same definition that the Office of Rural Health does. We let them make that designation, and we just use it. When we do differ from them a little bit when we talk about regions, which we didn't do here, but we do have publications where we do talk regions. We typically use the Oregon Employment Department's regional designation, but the urban rural designation we use the Office of Rural Health.
Right. All right, the next question, this is from Candace Covington. Do you have further drilled down data on nurse practitioners by specialty?
No, we don't. We have, and one of the reasons we didn't drill down is because we didn't ask in the survey. We were just really looking at nurse practitioners across the spectrum of practice for a nurse practitioner. And we just didn't have the data within our data, other existing data sets. The sample size was too small to allow us to do the breakout.
But I think it's also important to note that one of the things that we have talked about as far as the research agenda for OCN this year is because the role of nurse practitioners and the role that they're playing, particularly in providing primary care and in a lot of cases behavioral health services, I think that there's a big discussion right now among policymakers and a lot of other people that I talk to about how nurse practitioners are functioning now and that breakdown by specialty. So while this report is not necessarily going to drill down nurse practitioners by specialty, it is on the agenda of something that we're going to be looking at in 2019. So stay tuned. There might be another webinar near the end of the year that just addresses nurse practitioners if you're interested in that.
And we just received a question about compensation. We know, we suspect that compensation does play a role especially in different parts of the state, but we didn't ask anything about compensation in this survey, and because we're unable to do any geographic breakouts, we suspect that it would, that if the hospital can't pay what other hospitals can, it will likely go to facilities, long-term care hospitals, whichever, that can pay more than others, but we have no information on that based on this study at all. And that question was, does compensation information play a part in any of these data?
And the answer is yes, but we didn't collect it in this particular one.
Right.
I mean, I think that it is important to note that even though we didn't have a really huge sample size, like we didn't get 100% response rate, the responses that we did get were enough to be able to make the general assumptions for the entire state.
Right.
So for example, if you are in talent acquisition or if you're in nurse management at a hospital system and you see that the turnover rate is right around 10 or 11%, you can take that state number and compare it to your own turnover rate number to get an idea about how to benchmark how you're doing. So that's kind of the way we have done this survey in the past. We might adjust it in the future just to see if we can find a way to get at a little bit more data that's more actionable, that's actionable beyond what we're able to do. But it is important to note, we feel very confident in a statewide generalization based on the responses that we've gotten back. It's just we were not able to break it down geographically.
And I just want to throw in another couple points about the sample, or the response rate is, they were low, but we're seeing pretty low response rates in a lot of stuff we're doing. We've done a couple surveys over the past year where the response rates were pretty bad. We did a project for the state of Washington earlier this year. No, I mean, this 2019, early 2018, the response rate was bad. And I went to some meetings, and when I go to meetings where we have people from other states, I always ask them about response rates, just because we've had such an issue with it. And it's not just us. All the other states are reporting very poor response rate, but it just seems to be getting worse. Likely due to survey fatigue. I mean, we get surveys for everything. You go to the grocery store, you go to a fast food place, you get a survey. Mm-hmm. You can't buy anything without getting surveys. So I think people just get surveyed out. And we're following the practices that we've been following for years and years. We try to put everything online. We give them enough time to do it where they're not feeling pressured to do it, but we don't give them so much time that they forget about it. We send out notices. We are following best practices for survey research, but us and a lot of other organizations are having a really hard time getting high response rates. So I think what we're going to do when we do this again, this is really important data. Even though it doesn't say that hospitals need 55 nurses and 27 LPNs next year, it does give you a flavor for what it is, which helps planners and talent acquisition folks to kind of determine what the nature of the workforce is going to be looking like, and helps them plan for, budgeting planning, staff planning, utilization planning, and all those kinds of things. So one of the things we're going to do is we'll probably expand the type of data that we include in our demand report to be looking at stuff like from some of the data from the Oregon Employment Department that gives us some idea about what societal needs are for certain positions. And they also provide us some regional data, which is to be taken with this and combined to maybe create a richer picture of the state of the nursing workforce in Oregon.
And there's another question that came in. Are you able to separate the data on turnover for hospitals that have magnet status versus those that don't?
No, not in this data.
For the same reason.
For the exact same reason.
Yeah.
Well, we didn't ask them, so we would have to go back and identify them. But then the problem we would run into is we would be splitting 23 hospitals into multiple groups. And while we could do it, I would be I wouldn't be really confident in the results just because the samples are small.
That would have to be a different outreach if we were going to be adding that particular. All right, I think that's all the questions that I see online. Does anyone else have any other questions that they want to add to the question box? Please go ahead and put that in right now. If you are thinking that there's something that you might have a question with and you are not quite sure and you think of it later, you can always email us, and you can send an email to Rick. Go ahead and close this out and go to the next screen. Just get over this. There you go. So this is Rick's this is Dr. Allgeyer's contact information. You can email him directly. And you can also go onto our website at www.oregoncenterfornursing.org. We have the full report, both for not only just for the demand study, the most recent demand study. We have a listing of all of our demand studies, including the other reports that we have done over the years. And this year, as far as for the demand study, we've also included some interactive tables and charts. So if you are working on something on the fly and you don't have time to pull up the report and dig through it, there are some interactive tables where you can see some of these turnover rates, and you can start comparing them to each other, so you get a little bit better idea about maybe for a research project that you're working on. And I think that might be all the questions. I don't see any other questions. Looks like all of them. Okay, well, if that's all the questions, we might, oh wait, excuse me, there's one more that just came in. Is there any focus on finding out what roles RNs have, thinking of if case management is increasing in the community, hospitals, etc.? Any focus on finding out the roles of RNs in some of these settings?
No, the way we've asked the questions for this doesn't necessarily get into some of the functional occupations within it. Most of the questions we ask in terms of difficulty to hire and budgeted position really looks more at more attributes beyond the position, like education levels, those kinds of things, how new they are, and those kinds of things.
And also the idea of the question is, I mean, there is a question, is case management increasing in the community and hospitals?
Right.
I think that they're
Right.
just the use of, you know,
Yeah, I mean, we are definitely seeing that when we look at, but we're getting this information from the surveys that happened during renewal.
yeah.
And some of those kind of positions are they're not being responded to at the level we expect them to be responded to. So people are using other things. So for instance, there is a category that asks if you work for an agency or a traveler. There's so few, and we know just based on talking to people, this kind of data, that many more nurses or travelers are working for agencies than are reported in the renewal survey. And that's the same kind of thing we think we're seeing with case management. The numbers are so small.
Mm-hmm.
We know there's more out there because we hear nurses talking about it. When we were looking at some of the nurses endorsing into Oregon, a lot of those folks are endorsing in for case management.
Mm-hmm.
Because most of the nurses that actually endorse into Oregon don't live here, nor do they work here. And so they're working for insurance companies, they're working for health plans, they're working for pharmacy benefit managers, they're doing case management, they're doing online or on the phone triage, they're doing all those kinds of things. But when we go back and look at those kind of categories in our survey data, the numbers are very underreported.
So yeah, the short answer to your question is, this survey did not get at that question. However, we are seeing a lot of markers and evidence that case management, that RN and having a role in case management is increasing. And that might be something for future research and future exploration. Any last questions? All right. So thank you everybody for coming today. Thank you for joining us. This webinar is being recorded. We'll post it up on our website in case there's something like you'd like to go back and revisit. If you have any questions that come up afterwards that you think about after you've had a chance to process this along with your lunch, you're welcome to email Dr. Allgeyer, or you can also come to our website at the www.oregoncenterfornursing.org and see if there's any questions that can be answered there. And with that, I think we're going to log off. Have a wonderful rest of your week, and we look forward to talking to you again soon.
Thank you very much. Have a good day.